Okay. Now we're going to talk about substance use disorders, disorders related to the use of and potentially abuse of substances. First, a quick overview of the class of substances, kind of the terms used, because certainly there's all kinds of different slang terms for drugs and other illicit substances. But here are the terms that are used in the DSM. So you've got alcohol, amphetamines, um, your uppers, speed, methamphetamine, caffeine, yes, it's a drug, cannabis, which is the active ingredient in marijuana, cocaine, hallucinogens, which include a wide variety of drugs, including mushrooms, inhalants, so people that are huffing stuff, nicotine for those of you smokers, opioids, things like heroin fall into that category, phenylcyclidine, which is PCP, and then your sedatives, hypnotics, and anxiolytics. These typically being your prescription drugs like Xanax that people are abusing. Okay, so what things can you get diagnosed with related to the use of a substance? Well, the ones that we're most familiar with probably. Dependence, right, which we think of, it's the kind of DSM term for addiction, if you're dependent on a substance. Abuse, so if you're using it in an inappropriate way, maladaptive pattern of use. And then there's also the substance-induced disorders, right? Excuse me. Where you have intoxication, which all of the substance-induced disorders are substance-specific. So it's not just substance-induced disorder; it's alcohol-induced intoxication, right? Cannabis-induced intoxication. So because there are different patterns of intoxication for different substances, because it depends on how that chemical is affecting the brain. With typically there being some similar pattern of, well, when people are intoxicated on alcohol, it looks generally like this, and there's variability within that, of course, but it's different from how people look when they're intoxicated with something like cocaine. Okay? So you have intoxication, also substance-induced withdrawal when you stop taking it, and then substance-induced some other mental disorder, right? So depression, anxiety, things like that, which we'll come back and talk about in just a minute. Okay, so let's start with dependence, which again is kind of the DSM version of addiction. 3 or more symptoms in a 12-month period, and they can include one symptom would be tolerance, right? Which is you need more of the drug to get the desired effect, and or diminished effect with the same amount. So either having to use more to get high, detoxicated, or maybe somebody's using the same amount but they don't get as high and they kind of continue to get less high each time. And one kind of backtracking note here, this is a general list for dependence. Again, substance dependence, the precise criteria will differ slightly across different substances. They're pretty much the same, except for things like when we look at hallucinogens, there's no withdrawal requirement because people don't experience withdrawal from hallucinogens. The chemicals don't act that way; they don't build that up. So you have all the other symptoms, but not that one. But generally, these are the symptoms for most substances. So tolerance being one, withdrawal being another, which again is a syndrome characteristic of the drug used. So withdrawal looks different depending on what kind of drug you were using. And then the same drug or a similar drug is used to relieve or avoid withdrawal symptoms. So even if you don't have withdrawal symptoms, but now let's say you're somebody who's dependent on alcohol, they're not drinking to get drunk anymore, but they're drinking just enough to keep from getting the shakes, right? So if they're having to use that drug to keep from getting withdrawal symptoms, that counts toward withdrawal, even though not having the other kind of the classic withdrawal symptoms. Or people that addicted to heroin that are going to a methadone clinic. So that's a similar drug used to avoid or relieve the withdrawal symptoms. So tolerance and withdrawal are kind of what we often think of as being the key features of addiction, right? Oh yeah, if you're addicted, you have tolerance and you have withdrawal. And so they're in here, but you don't have to have them because there are several other symptoms you can have, and you just have to have 3 of all these symptoms to be diagnosed with dependence, and not necessarily including tolerance or withdrawal, but frequently you do have one or both. Okay. Other symptoms including using more of the substance or using it for longer than you intended. So I'm just going to have a beer and then going through a case. Right. Loss of control of use. So this is where people that have tried to quit or cut back and not able to do so. Lots of time spent related to the drug, either getting the drug, using the drug, so take a big chunk of time getting high, getting stoned, getting drunk, or lots of time recovering from the use. So basically, it's impacting your life. This is kind of a clinical significance type criteria, where it's sucking up time. Important activities are given up. So, quitting school, quitting work, quitting socializing with your friends, not taking care of your kids, those types of things. Excuse me. And then the last one, someone keeps using even though it causes or worsens a physical or psychological condition. Okay, somebody that has developed gout, but keeps drinking alcohol even though that makes it worse. Well, if you know it makes it worse, but you can't stop drinking or smoking or snorting, then that's another indicator of dependence. Okay. So you just have to have 3 of those in a 12-month period. And it's not for 12 months, it's within a 12-month period. And then you have your specifiers, with or without physiological dependence, and this goes to whether or not those tolerance and withdrawal are present. So again, tolerance and withdrawal don't have to be present, but they might be, and often it's an important thing to know. That's why there is that specifier, because depending on the substance, if there's potential for withdrawal, which is kind of more of this evidence of a physical addiction in addition to a psychological addiction, then there's going to probably be a more significant need for medical intervention to manage the withdrawal so the person doesn't get really sick or hurt themselves. Then you also have your core specifiers in terms of where somebody's at in terms of recovery or remission. So you have early partial remission. This is where for at least a month, but less than a year. So 1 to 12 months of meeting, still meeting at least one or more criteria for dependence, but not all the criteria. So not 3, so 1 or 2. So maybe still having using more than you intend, or well, usually it's the still using, right, and trying to quit, so not able to quit yet, so can't control it, and it's still maybe sucking up more time, but maybe now the use is more under control, where it's you're able to go to work and do those kinds of things. So that'd be early partial remission. Excuse me. And then if you keep that up, right? So for over a year, you still are using some, so still have at least one symptom, but not all of them. That would be sustained partial remission. And then you can also have sustained full remission. So this is when you have 12 months, a year of not meeting any criteria. So in this, the time for this is based on some research that suggests that relapse is very common. Right? So people quit, and then they come back and use again, and they quit, and they come back and use again. And there seems to be this break that if you can stay quit for a year, the odds are better than if it's less than a year that you're going to maintain your sobriety. Right? So if you've been sober for 3 months, 4 months, well, there's still a chance you may relapse. If you can make it to 12 months, now there's kind of a drop-off in the odds of relapse. There's still a chance you can relapse, but it's less than if you've been sober for less than a year. So substance dependence now. Substance abuse. Excuse me. which you can use those same specifiers in terms of remission for. It's a maladaptive pattern of use leading to impairment or distress as shown by one symptom, just one, in 12 months. So it's a failure to fulfill major role obligations. So what's a major role obligation? Things that you're supposed to do that are big time. So it's not, oh, I didn't turn in a paper because I was stoned. That's not a major role obligation. But if you quit going to class because you were too high or you're recovering from getting high, that's failure to fulfill a major role obligation. If you're not feeding your kids, right, not showing up for work, kind of the big things that you're supposed to do. If your use leads to impedes your ability to do those things that you're supposed to do as an adult, then we've got failure to fulfill major role obligations. And obviously, if we extend this downward to kids, well, what are their major role obligations? Then it's like, well, they don't have to go to work, but they do have to go to school. They do have to do their homework. So if they're not doing their homework because they're getting high, for them that may be their major role obligation. So it's very contextual what a major role obligation is. Or use in situations where it's dangerous to use, and this is usually driving, right? So if you drive while intoxicated and do it consistently, so again, it's not doing this once, but it's a pattern of use. So if you regularly use situations where it's dangerous to use, where because for a pattern has to be at least 3 times, right? Three dots make a line, a trend. Sorry. So multiple times doing that, or substance-related legal problems. So getting arrested or ticketed because of your use. Continued use despite social or interpersonal problems associated with use. What does that mean? It means the people around you, your social group. This could be, your partner, your family, whoever. You fight about it, right? If you're fighting about your use, and so it's causing interpersonal problems, but you don't stop. It's like, well, I could solve these interpersonal problems if I stop snorting coke. We'll stop arguing about it. Well, keep snorting coke despite these problems. Okay, that's abuse. Okay, so again, all it takes is one of those in kind of a repeated way. Usually it's more than one. Note here, this is kind of an important thing, criteria are not met for dependence for that particular substance. So if you do all this stuff, but you also meet criteria for dependence, we don't diagnose you with dependence and abuse. So dependence trumps abuse, right? It's kind of a bigger disorder. And so if you meet criteria for dependence, we know you meet criteria for abuse because it subsumes the smaller diagnosis. And often abuse precedes dependence. So you can be a substance abuser without being dependent yet, but typically what we say is, well, they're going to become dependent. Once they're dependent, we no longer call them substance abuser. Now they're substance dependent. A couple things to note. Can't be diagnosed with caffeine abuse or nicotine abuse, although you can be diagnosed with nicotine dependence. And you also can't be diagnosed with caffeine dependence. So why don't we have things like nicotine abuse in here or caffeine dependence? Well, because too many people on the committees that made up these disorders smoke and drink coffee. So and if we all do it, it can't be pathological, right? Maybe. Okay. Intoxication. It's development of a reversible substance-specific syndrome due to a substance. So you start doing things differently. You have these signs and symptoms that are substance-specific. So intoxication looks different, again, depending on the substance. And it's reversible. So it's not you take this drug and it changes your brain forever. You're intoxicated. No, it changes your brain and your behavior for this period of time. And eventually your body will metabolize whatever you put into it, and you'll stop being that way, and you'll no longer be intoxicated. There are maladaptive behavioral psychological changes due to the effect of the substance on the central nervous system that develop during or shortly after use. Right? This is all, and when we say effect on the central nervous system, we're saying it screws up your brain for a while, right? And what are maladaptive behavioral and psychological changes? Well, different things. You could become really paranoid and be a psychological change. Behavioral, if you become really aggressive and are kind of louder and more of a jerk, that would be a behavioral change. If you become more withdrawn, you curl up in a ball on a couch, a behavioral change, right? And it's due to the effects of the substance, and it's not. It's maladaptive. It's not a good thing. It's not that using the substance. If say baseball players take steroids, wow, they can recover from injuries faster. That's not substance intoxication. The substance is having an effect on their bodies, but that's not intoxication. It's whenever it does something to you that is not so good and makes you're getting through life more difficult. And then the symptoms, of course, are not due to a general medical condition or other mental disorder. So why do we have this diagnosis, right? It's a temporary state. If we know it's going to go away, why would we have that? Well, largely it's to help in communication, right? So if somebody comes into the ER and they're actively hallucinating or they're belligerent or whatever, and for the police report, for later kind of legal stuff, we can document, okay, they aren't this way because they have schizophrenia or whatever, or they're a jerk. They were high, right? So you document when they came in and they had lacerations to their arms. Client was suffering from alcohol intoxication. Right? So it's all about trying to explain behavior. Won't talk about all the patterns of use, but give you just one example. Alcohol intoxication is one probably most people are familiar with. The behavioral or psychological changes include things like inappropriate sexual or aggressive behavior. Right? Alcohol tends to have the effect of lowering inhibitions. And if you think about ADHD and its association with the prefrontal cortex, and the prefrontal cortex's job in terms of inhibiting stuff, so alcohol does kind of the opposite of psychostimulants. Or psychostimulants charge up that part of your brain to inhibit stuff. Alcohol kind of disables it, and you become less inhibited. There also can be mood lability, and lability means change. So mood can swing rapidly. Happy, laughing, having a good time. Think of one sad thought, and the mood quickly shifts to sadness, and then can shift back to happy again or to anger. So it's kind of a lay-by mood, one that can shift easily. Impaired judgment. And this is kind of this isn't just I've heard stories, but they've documented. Having college students come into labs and getting them drunk. They can't think as clearly. They can't make discernments as efficiently or as quickly. Also may have impaired social or occupational functioning. So you can't do your job and you can't relate to other people the way you would if you weren't intoxicated. So you have that, and then we also talked about the one or more central nervous system related symptom. Right? So there's evidence that it's screwing up your brain directly, and it's not just because you could have all the other stuff and it'd be kind of placebo, right? We see those studies where they give people fake beer and then they act like they're drunk. So you can get those behavioral psychological changes without a chemical impact on the brain. Less likely to have the CNS related things in terms of faking. So things like slurred speech, excuse me, incoordination, clumsy, falling down, an unsteady gait, not being able to, lack of smooth coordinated movements, because again, parts of your brain are being temporarily disabled because of the poison in your body. Nystagmus, which is a persistent, rapid, involuntary, and oscillatory movement of the eyeball, usually from side to side, so eyes jetting back and forth. Impairment in attention or memory, and at high levels, even potentially stupor or a coma. So, sounds like fun. Okay, substance withdrawal, as I said before, is the development of a substance-specific syndrome due to cessation or reduction of heavy or prolonged use. So again, people often think about withdrawal being, when you quit, you have withdrawal. Sometimes even if you try to cut back, the body says, hey, where's that chemical that I've gotten used to, right? So even a reduction of a substance can lead to withdrawal symptoms. Because remember, the body's all about homeostasis. And that's why we have tolerance, right? Start getting the substance, the body goes, oh, there's this weird substance, let me accommodate for it. Oh, here's more of that substance, let me accommodate again. So the body's ratcheting up to meet what you're doing to it. And then when you take it away suddenly or quickly, the body's like, hey, where's that stuff? I've gotten used to having to deal with the substance that's not there. Now the brain's going to do some funky things. And again, typically not after one time, getting drunk one time, and then they're never drinking again. Probably not going to have withdrawal. It's usually after prolonged use or really heavy use. It's a syndrome that causes distress or impairment. So if you have some withdrawal symptoms, but it doesn't really impede you from doing anything, then it's not diagnosable. And again, it's not due to a general medical condition. Symptoms aren't due to a general medical condition or other mental disorder. Okay, example again using alcohol. 2 or more of the following within several hours to a few days after cessation reduction. Autonomic hyperactivity, which is things like racing pulse. So again, alcohol depresses the autonomic nervous system, kind of pushes it down. So when you stop, it bounces back and is maybe overactive. Increased hand tremor, right? The shakes. Insomnia, can't sleep. Nausea and vomiting. Transient visual, tactile, or auditory hallucinations or illusions. Yeah, hallucinations, right? From not drinking. So this isn't somebody that's high and they're seeing things. This is somebody who's a pretty heavy drinker, stopped, and then they're having hallucinations because the brain is trying to deal with the absence of a chemical that it's gotten used to. Anxiety, which if you're having hallucinations is not surprising, and potentially even grand mal seizures. Not included in the words here for the criteria, but one thing you'll read about elsewhere are DTs for alcohol withdrawal, delirium tremens. This is where you have a combination of frightening hallucinations and tremors. So you get that hand tremor and the transient hallucinations. You get those together, they call it DT. So you may see that phrase. Notably, in terms of withdrawal, there aren't withdrawal patterns identified in the DSM for cannabis or hallucinogens. Those are things like marijuana and LSD don't seem to have a identifiable withdrawal pattern, which suggests less likely to have kind of that physical level of addiction, but certainly very likely to have a psychological level. Now, as I said before, there are these other substance-induced things other than intoxication withdrawal where you have then disorder. So things like substance-induced delirium, right, where when you're delirious, it's an alteration in consciousness where you're not able to attend to things in your immediate environment and often don't know where you are, who you are. There's substance-induced persisting dementia, right, and persisting amnestic disorder. Both of those being where you've used a substance so much, you've fried brain cells, and now those cells aren't going to work. They aren't coming back. It's not intoxication. Now you've caused permanent brain damage to where you're going to have some cognitive dysfunction. And dementia being kind of broad cognitive dysfunction, and amnestic disorder being limited to memory. Substance-induced psychotic disorder, mood disorder, anxiety disorder, sexual dysfunction, sleep disorder, pretty much any disorder in the book, substances might cause them, right? Or might induce them. And when we talk about this, we're talking about where the symptoms of the mental disorder occur during intoxication or withdrawal and are exceptional. Excuse me. So they're in excess of what you typically see in withdrawal. So sometimes it's just, okay, this is cocaine withdrawal. Oh yeah, you're going to see some of these things, and it looks a little like a mood disorder, but it's just cocaine withdrawal, and it'll stop. You add, substance-induced mood disorder or substance-induced anxiety disorder, whatever it is, if the symptoms are more significant than what you typically see in withdrawal. So often these things are when you're high or when you're getting off of a drug. You have the mood symptoms, anxiety symptoms, psychotic symptoms, and again, if they're beyond the typical withdrawal or intoxication syndrome, you tack on substance-induced whatever disorder. In terms of a substance being the origin, the cause of a mental disorder, you know, we think about the temporal relation of onset and offset of use. So if you never had the symptoms before you start using, and then you use, and then you start having symptoms, then yeah, it's probably substance-induced something. And if you stop using, and those symptoms go away, it makes sense. And then the other thing we think about are the typicality of symptoms, right? So, and this has to do with often whenever we're trying to figure out, well, this looks like a mood disorder, but gee, it's kind of weird. I wonder if it's because they got high. I wonder if it's a substance-induced mood disorder. So if there's somebody who's 45 years old and has a manic episode, and they've never had a manic episode ever before in their life, that's atypical for what we know about bipolar disorders. So then we're going to start suspecting that it's maybe a substance-induced mood disorder, where they look like they're manic because they did a lot of cocaine. On the other side, if somebody comes in and they report a history of methamphetamine use, and they're reporting some paranoid delusions, we're probably not going to say, oh, they probably have schizophrenia, because, well, yeah, paranoid delusions are typical of meth use, so we're not going to add a thing. But if they're on sedatives, so they take a bunch of Loratab, and they have these paranoid delusions, well, that's not typical of intoxication or withdrawal from sedatives. Maybe they have this substance-induced psychotic disorder, if the onset is related to use, or they could just have a separate psychotic disorder. One thing to keep in mind, the only persisting disorders, so most of these things, when you have substance-induced whatever, it's not that, okay, I never had a mood disorder before, I took a drug, and now I'm going to have a mood disorder. No, it's usually when you're high or when you're going through withdrawal, you have the symptoms of a disorder. The only things right now where you use drugs, usually a lot of drugs, and you get a disorder that doesn't go away, so a persisting disorder, are your persisting dementia and persisting amnestic disorder. Not enough evidence yet for other disorders. However, research ongoing for looking at things like substance-induced persisting psychosis due to marijuana use. There's some evidence that individuals will develop a psychotic disorder following the use of marijuana. Most people think that when that happens, the person probably was already at risk for a psychotic disorder. There's a history of psychotic disorders in the family, but that the marijuana use may trigger that psychotic disorder. But not in the DSM yet. Research on. Okay, in terms of epidemiology, what we know about how many people use, when they use, what they use, that kind of thing. We know that use doesn't always lead to dependence, right? Excuse me. In terms of what drugs are most likely to lead to dependence once used. So the most addictive drugs, people that use once, a couple times, how likely are they to go on and develop pattern of dependence? The most addictive being nicotine, 24% of people, slightly more addictive than heroin. So if you're a smoker out there, think about that. Then cocaine, then alcohol being less addictive than the others. And a variety of reasons probably for those patterns, including the physical properties of the drugs, and then also social contextual factors related to the appropriateness of use. Although important to note that nicotine and alcohol, both socialized to be fairly appropriate in the States, but pretty different patterns of dependence. The average amount of time between initial use and dependence for those who become dependent is 2 to 3 years. So again, it's not that somebody starts smoking weed and then in a few months they're hooked. On average, it takes a while to get to the level of dependence, right? And for criteria-wise, it has to be at least a year. You have to have 12 months of these 3 symptoms. Typically, they kind of go from use to maybe abuse, and then graduate to dependence. So mention things in terms of gender differences and alcohol abuse. The levels of alcohol abuse are similar until between men and women, between male and female adolescents, until about the age of 17. And then after that, men race ahead and are much more likely to be diagnosed with alcohol abuse and dependence. Variety of theories about this, including possible influence of hormones, but then also quite likely some societal influences. And we see differences in other disorders too that may be related to this in terms of women being more likely to be diagnosed with depression. So there may be more of these men who may be suffering from major depressive disorder, but then are self-medicating with alcohol, and so being identified as having alcohol abuse, and that's kind of masking the depression. In terms of the prevalence of dependence, so how many people are out there that are dependent? And you would think, okay, well, the drugs that are most addictive, we'll see that same pattern in terms of how many people are dependent. And in fact, you do see tobacco being number one, the most addictive thing, and more people addicted to it. But then next comes alcohol, and it beats heroin and cocaine, largely because of availability. And then cannabis is ahead of cocaine, which is ahead of amphetamines. And a lot of people are surprised that cannabis is up here ahead of cocaine, because cannabis doesn't seem to have a strong physical dependence component, right? Where not everybody that uses it develops dependence. But more people are dependent on cannabis than are dependent on cocaine, which again probably relates to economics and availability of the substance. So even though it may not have a high addictive profile, there's a lot of people who are dependent on it. Abuse and dependence rates decrease after young adulthood. So, how many people are abusing, how many people are using? If we look kind of cross-sectionally and then advance across time, so, wow, these teenagers are all getting stoned, and then once we get in the young adulthood and they can afford it, they're still using a lot, get past young adulthood, it goes down. Why do the rates decrease? Well, probably a variety of reasons. One, and after young adulthood, you have to get a job, right? You can't just get high all the time, and you don't have the shelter that some people have of the family home, where you have fewer social role obligations, major role obligations that you have to meet. So when you have deadlines and responsibilities, it's harder to continue to abuse and be dependent. That's probably one reason. And then another would be the negative consequences of use. People get locked up and they die, and so they drop out of our statistics. So you will see some adults in middle adulthood and older adults who are dependent on substances, but less likely than younger adults and adolescents. In terms of comorbidity with other disorders, as a rule, I'd say expect it, right? High rates of comorbidity across the substances for many reasons. One, sometimes it's because the substance use is related to the other disorder, right, where they're using the substance to help to try to self-medicate and treat their own symptoms. So think about anxiety disorders, mood disorders, not feeling bad, kind of negative emotion, and trying either to feel good or to feel something or to just not feel bad. Kind of makes sense. And interestingly, even for schizophrenia, right, we see high rates of nicotine dependence. A lot of smokers with schizophrenia, and that seems to be related to chemically, the nicotine activates these muscarinic receptors and help with some of the symptoms of schizophrenia. So, for some of those people, they are somewhat effectively self-medicating, taking the edge off some of their positive symptoms of schizophrenia. Unfortunately, they're probably getting cancer, but there is something to be said for, these drugs are having an effect. So sometimes people are trying to self-medicating. Sometimes you have comorbidity because the drug use causes symptoms. Right? And sometimes in that very kind of substance-induced way, but sometimes it's more about this pattern of use is causing problems in your life, right? So, one of the things for uh, substance dependence, you persist using despite it causing interpersonal problems, right? So if you're using and it's causing interpersonal problems, it leads to isolation. Well, when we get isolated, we have fewer social contacts. We're at greater risk for depression. Right? So substance use is a risk factor for other disorders. So it can go both ways, right? It could be the other pathology comes first, and then the substance use, or the substance use can come before the other pathology. Why do people abuse substances? Why do they become dependent? We'll look at alcohol just as an example. Can't go over every possible thing. But a lot of commonalities across substances with alcohol. If we break it down into three kind of classes: social factors, biological factors, and psychological factors. Looking at social factors, things like culture. There are things like cultural attitudes toward drinking and drunkenness. Right. So in Muslim communities, people that strict observers of Islam, they don't drink, right? And so fairly low rates of alcohol abuse and dependence in those communities. It's not non-existent, but much lower compared to other communities. In people who are traditional, kind of Orthodox Jewish, they don't oppose drinking, but there's a cultural disdain for intoxication. It's not appropriate to be drunk, especially in public. So again, there we see lower rates of problems with alcohol dependence. Parenting. So how do parents play a role? Well, one, the modeling. So if they drink or use drugs and the kids see that, there's one influence. Also, their attitudes toward drinking. If they're totally against it, if they think it's social, if they're do whatever, those attitudes matter. And then also, if they're users themselves, then the substances are going to be in the home, and then the kids have easier access to using. So whether or not a child is going to begin smoking or drinking or using whatever, if it's in the home and available, more likely. But the biggest kind of influence that parents have is whether or not they are monitoring their kids, whether or not they know where their kids are. Right? Parents that are low in parental monitoring, kids go do whatever. I've got, and for a lot of reasons they don't care. It could be this reality is they have to work. They're working 16-hour days, whatever it is, and not able to be around to watch the kids. Those kids are at greater risk for developing alcohol abuse or dependence. In general, for all these kind of combined reasons, parents who have alcohol dependence, alcohol abuse, are more likely to have kids that use than parents who aren't dependent on alcohol. But peer and sibling influences are even stronger. Right? So if your peer group uses alcohol, or your siblings, that's a better predictor than anything about the parents. Okay? So you do the best you can as a parent, but what it often comes down to is who are they hanging out with. And an argument can be made that who they hang out with can be influenced by the parents, but from just a statistical point of view, if we want to say, well, what are the odds that this kid is using alcohol? Well, ask their friends if they're using alcohol. Biological factors. One thing for alcohol and other substances too is the initial physiological reaction to using. So how your body responds, if it's a pleasant reaction or a negative reaction, is going to play a role in the likelihood that you're going to use again. And the likelihood you're going to use again obviously influences whether or not you become dependent. So we know that 30 to 50% of people with Asian ancestry will react to alcohol with flushed skin, nausea, and abnormal heart rate. Not that fun. And so, not surprisingly, we see lower rates of alcohol dependence in Asian people. Kind of tying in biological and social factors, just a quick story. My first beer, my mother apparently was a savvy person when I was, I don't know, probably 8, 7 or 8. Asked for beer because family, bunch of drinkers. And she said, "Oh, sure, let me get it for you." And she got a warm Pearl Light, 16 calories, poured it in a plastic cup, and said, "Here you go." And it was so disgusting. My initial physiological reaction was to spit it out because it tasted really nasty, and I didn't drink again for about 10 years. So the first experience with a substance, anecdotally, I say definitely plays a role in the likelihood of developing a pattern of use. Genetics, like everything else, plays a role. Influences both the level of social drinking and the likelihood of a disorder in terms of looking at twin and adoption studies. So what things genetically are going on? Because again, there's not an addiction gene. Well, it's probably the genes that are related to for alcohol dependence that influence our metabolism of alcohol. So the genes that make up your liver, things like that. Also, probably genes that influence the part of your brain related to sensation seeking. People that are higher in sensation seeking, and also the genes related to inhibition, the part of the brain that prefrontal cortex again that regulates inhibition. And then neuroanatomy and neurochemistry, so how your brain is structured, which how it's structured is dependent on genetics and experience and nutrition, all that stuff. Neurochemistry, how it's working, will play a role because drugs typically affect the reward pathways in the brain, right? So you got your mesolimbic dopamine pathway. And there may be an exaggerated activation of the endogenous opioid system. So for some people, substance comes in and their brain is wired in such a way that it feels really friggin' good. Right? And for alcohol in particular, we know that alcohol temporarily increases serotonin activity in the brain. So people that maybe have underactive serotonergic activity might be at greater risk for developing a pattern of dependence because drinking makes them feel more closer to normal. Psychological factors, expectancy effects are big, as kind of alluded to before with those the studies on with near beer, with fake beer. Placebo studies have found that behavior is affected by expectancy, what you tell people about the effects of a drug. People that have more positive expectancies of the effect of alcohol use more of it. So you bring people in and say, okay, you have this alcohol, and it's going to make you feel friendly and sociable, and da-da-da. They're more likely to drink more. Whereas if people are going to say, we're going to have you drink this alcohol, we're doing a study, we just want to caution you that it may make you feel nauseous, you won't be able to think clearly, da-da-da. Tell them all these negative things, they're going to drink less of it. Right? So where do those expectancies come from? Well, we're going back to probably those social factors, right? In terms of what are people telling you about what it's like to get high. The tension reduction hypothesis is the idea that we drink to feel different, and usually it's to feel less anxious, sometimes just to feel less, that there's kind of tension built up, there's emotional charge going on in a person, and that they're using a substance, in this case alcohol, to feel less of that. Which probably there's some good evidence for that. Another way of thinking about it is looking at attention allocation, right? Because we know that alcohol interferes with the capacity for controlled and effortful cognitive activities. Right? You can't think straight. Right? And this is used to explain why drinking makes some people happy and others sad. Right? It depends on your environment while intoxicated. If you are in a happy place and drinking, you're not going to be thinking about sad stuff. You can't pay attention to other stuff than what's immediately around you. Whereas if you're by yourself and alone and sad and drinking, you're not going to go think about happy stuff. Right? So the idea here is that people may drink to not think about stuff. So attention reduction is about not feeling stuff. Attention allocation is about I'm not going to be able to think about this bad thing if I get drunk, which only works if you set up your environment appropriately. Because even if you go to try and maybe forget an ex-boyfriend or girlfriend, say I'm going to go to a party and get drunk and I think about them. When you go to the party, you get drunk, you see someone that looks kind of like them, Now you can't think about anything else, and now you're drunk, and you can't allocate your attention appropriately because you've impaired your cognitive ability, and now you're going to obsess about that and be sad, and it's not going to do what you wanted it to do. Okay, in terms of treatment, psychopharmacology, there's a couple of drugs that are used in treating substance use disorders, and there's not, a pill to replace the pill always. With heroin, you do have methadone, which is a chemically similar substance to heroin, but people don't get as high, but it helps reduce the withdrawal symptoms, and they kind of start you off at a fairly high level of methadone, and then titrate you down to lower levels so that people can stop using the drugs, opioids, without experiencing severe withdrawal syndromes. For alcohol dependence, there are drugs that do a couple different things. You have things like antabuse, where you take this pill, and then if you take this pill, and if you go out and get drunk, you're going to get very sick, right? Which discourages you from getting drunk. The problem is you have to take the pill for that to work. So if you really want to get drunk, you just don't take the pill. And then, but if we kind of think about psychopharmacology, taking psychoactive drugs to stop using these other psychoactive drugs, sometimes it makes sense in terms of if the pattern of use is because of some other disorder, because of anxiety or depression. Well, we're going to treat the anxiety or depression, and if we do that in part with psychopharmacology, with pills, then you may not have to use the other one. So somebody that's smoking a lot of weed because they have generalized anxiety disorder and they're trying to take the edge off their anxiety, we may end up putting them on an anti-anxiety drug. And in some ways, you're going to be substituting one drug for the other. And when I've talked with clients about this, it's like, just kind of being straight up with them that, you are substituting one drug for the other, but with this drug, you're not going to get arrested, right? And you know how much of the drug is in it. When you go buy weed, you don't know how much THC is in there. You don't know what else, if somebody's laced it with something. It's riskier, right? This drug here, even though you may not get the same effect, and it may not be as kind of, it may not have the kind of the same social aspect you have with marijuana. You're not going to go through a bunch of friends and say, hey, let's go take our anti-anxiety medications and hang out. You're going to miss that, but it's going to be safer, and it'll still do that part that you want in terms of taking the edge off your anxiety. Individual psychotherapy, a lot of different things, obviously, that you can do. A lot of different theories about how to work with people with substance dependence. I think one of the most important ideas within individual psychotherapy in terms of the treatment of substance-dependent substance abuse is the emphasis, once you've kind of made progress in terms of somebody maintaining sobriety, on relapse prevention. Right? And this is the idea that understanding that relapse is highly likely. And talking to people about, okay, you've been able to be sober this long. If you go out and you have a drink, if you go out and get high, that's a slip. It's not a fail. Right? Because there tends to be this thing that we do. We set ourselves up cognitively where we slip one time and we go, well, screw it. Might as well get wasted. I had one drink. I'm off the wagon. Right? It's kind of this all or none thinking, which is very it's kind of CBT, very much kind of taking advantage of that language. But to kind of inoculate people against it and say, no, if you have one drink, it's not great, but it's not the end of the world. Just don't have a second drink. Right? So warn people that, yes, you will most likely have a slip, but a slip isn't a relapse. And that seems to prevent full-blown relapses. So I think that's an important component just to mention here. Detox and inpatient treatment. If somebody's been have a heavy pattern of use, especially for alcohol or opioids, they may need to go to a inpatient facility, and go through detox. And this is where they're taking the toxins out of your body under a controlled situation. Because again, you can have grand mal seizures and die because you stopped getting high, getting drunk, whatever. So you have doctors and nurses monitoring you, making sure you're getting all the fluids and food and that kind of stuff. And those places do a pretty good job of getting people sober safely. But few people can go to detox in a 30-day inpatient and get out, and that's all they need. Right? It's often an important first step, but typically they're going to need something else, be it individual therapy or group therapy, which you often get group therapy in inpatient as well. There's a big component of substance dependence treatment, in terms of being able to learn from others and talking about shared experiences. And then probably the biggest player in the treatment world for substance dependence are the 12-step programs, most well-known being AA. The evidence on the efficacy, it's a little mixed. If people stick with it, people that stay in AA for 30 days, pretty good rates of success. But if you look at everybody that ever went to a meeting, the record's not so good. Because people that that for whatever it doesn't fit with them because of their worldview, personality, whatever, they drop out early and may not come back, or at least not for a while. But people that can stick with it, those programs do tend to have a fairly good rate of success. Okay, that's all for now about substance use disorders.